and welcome everyone. My name is Shiral, and I'm an HoFH patient ambassador and the project lead for HoFH Awareness Day. And I have the pleasure to co-moderate today's webinar with Professor Albert Bigman. This webinar is the second in our special trilogy as part of the HoFH Awareness Day campaign. And today, we're going to focus on the golden standards in HoFH management, highlighting the established treatments that form the foundation of care for individuals living with HoFH. Now, these webinars emphasize the importance of partnership between the medical community and patient advocates. So today, the discussion is interactive between medical experts and patient experts. So thank you once again for being here and part of this important conversation. And thank you to our panelists who will be hearing from them shortly. Before we begin, a few housekeeping notes. This webinar is being recorded and will be available on FH Europe Foundation's YouTube channel. If you have any questions, please post them in the Q&A box and we'll get to them at the end of the discussions. And we'll aim to answer as many as possible live. And please refrain from asking specific questions related to personal health records or treatments. We also love to hear from you, so please let us know where you're joining from and who you are in the chat box. Now, it is my pleasure to introduce my co-moderator, Professor Albert Bigman, an esteemed pediatric cardiologist and researcher from the Netherlands and a member of FH Europe Foundation's Scientific Advisory Committee. Over to you, Albert.
Thank you, Cheryl. And it is my pleasure to welcome Dr. Julia Brands from the Department of Internal Medicine and Cardiology of the University Hospital for Aachen. And she is also a member of the Imperial Center for Cardiovascular Disease Prevention of the Imperial College in London. So she will tell us all about statins and ezetimibe. Julia, the floor is yours.
Thank you very much. So, hi everyone. I'm really curious to the discussion afterwards, but before we have the discussion, I want to show you a little bit about, firstly, statins and ezetimibe. So can you just let me know if you can see my screen correctly?
Yes.
Fantastic. Yes. So I think, why would we start? I think most of you know statins and ezetimibe. The first medications you would be prescribed if you have any issues with cholesterol at all. And the same is true for patients with homozygous FH. And therefore, before we start here, my disclosures, I have some affiliations with some pharma companies in terms that I presented on some of their occasions. However, I'm not paid for this talk in any matter. So I don't want to scare you, but let's dive deep into, firstly, the liver cell. Why do we want to look at the liver cell? The liver is actually the only organ that is able to excrete cholesterol. Every cell in our body is able to produce cholesterol, but liver is the only thing that is excreting cholesterol. Therefore, it is an important target organ of all the lipid-lowering therapies, directly or indirectly, that we use in current practice. So what you see here is in yellow, what I call the cholesterol production, or we call the cholesterol production. And this has several steps. And at the end, if we are not treating with anything, we see cholesterol is produced in a liver cell and then goes into the cholesterol particles. These cholesterol particles are then put out from the liver into the bloodstream where they circulate, go to their several targets, and afterwards they go back to the LDL receptor and are internalized to be broken down. So what happens if we put statin into the game? The statins are actually blocking cholesterol production at a certain step within this row. And this leads to a depletion of cholesterol in the liver cell. And now, let's put it like this, the cell is a bit panicking, and therefore it has some mechanisms to now raise the cholesterol levels again within the liver. So on the first note, what we see is the liver tries to get more cholesterol from outside. Therefore, in patients without homozygous FH, or just only to a certain extent in patients with homozygous FH, but this is the main act of statins, is the LDL receptors are more produced, more LDL receptors are on the liver surface, and now the liver acts like a vacuum, sucking in all the circulating particles with cholesterol. However, in patients with homozygous FH, as we just learned on Tuesday, it is exactly the LDL receptor that is defective. But we will see in the next slide that to a certain extent, still this statin approach works, mainly based on the residual activity that is within the few receptors left. However, there is the speculation that there's, of course, another target for the statin. So due to the low cholesterol within the liver cell, also the production of cholesterol particles decreases, and therefore overall, independent of the LDL receptor, we have a decrease in circulating cholesterol. More on statins is also they decrease inflammation. If atherosclerosis, so plaque within the arteries, is already present, then it stabilizes these plaques, so they are less of a risk to rupture and cause, for example, myocardial infarction. So statins are beneficial on several levels. We have a huge discussion on, or I think many patients have a discussion on, which is the best statin, what should I take, what shouldn't I take? And so on the left-hand side, what you see, this table is actually not true for patients with homozygous FH, but this is mostly what clinicians know. So you have atorvastatin and rosuvastatin here in the first row, which are called the high-intensity statins because they are assumed to reduce LDL cholesterol by 50%. But I brought you, and this is a publication from 2002, on the right-hand side, I brought you a huge table, and you don't have to read all the numbers, but what I want to show you here is, for example, for atorvastatin, that is the last statin in this row here, there are several studies listed. And what you can see, all these studies were done in patients with homozygous FH. And in these patients, and this is what I highlighted with the red box, LDL reduction is not 50%, but it's a huge variability from 0.9, which is almost the last number in the red box, to 35% in LDL reduction. So you see, it's not an approach for all, but the majority, even of patients with HoFH, they benefit from statin therapy through LDL cholesterol reduction. Now, a very common topic, if we talk about statins, is side effects, especially muscle pain. And I think what is very, very helpful to know is that in most patients, statins do not have side effects. They are very well tolerated. And additionally, yes, muscle pain is the most common side effect of a statin. But if we look in depth, then we see that most often the pain patients feel might not be attributed to the statins, but statin therapy is common and pain is common, especially if you get to a certain age. However, if you are in pain and you think it's associated with a statin, you should contact your clinician. If the pain persists, please have your lab values checked. There's the so-called value creatinine kinase. It's an enzyme of the muscles. And if this is increased, then yes, in some patients, we have to stop the statin therapy. The tremendous side effects like this muscle breakdown, which we call rhabdomyolysis, this is really, really rare. Yeah, okay, this is nothing you have to be, this is really nothing you have to be concerned about. It's really rare. And what should we do? When we feel like there is statin-induced muscle pain, well, then firstly, we have to stop. And secondly, we have to switch the statin. So I brought you this down here. This is more on a biochemical level, but we think about it that there are two groups of statins. On the one hand, we have water-soluble statins, like rosuvastatin, pravastatin, simvastatin. On the other hand, we have fat-soluble statins. And we think this is not clinically proven, this is important, but this is more an idea coming from the biochemics that the fat-soluble statins could provoke more muscle pain because it is easier for those statins to penetrate other cells beside the liver cell where it's needed. So we think that this could promote more muscle pain than the water-soluble. And therefore, I'm very happy that the two high-intensity statins, rosuvastatin and atorvastatin, are in different groups. So we can switch from one to another. Lastly, regarding statins, I think this is I just brought you this study because I think it's really interesting. So here in this study, we had patients that already had issues with the statin therapy and therefore quit therapy. And now these patients were asked whether they wanted to participate in a study to be treated over 4 months, either with a placebo, with a statin, and now here comes the clue, or they were not treated for 4 months. And then we looked, or the authors looked at whether these patients would show some symptoms in terms of muscle pain again. And what you can see on the right-hand side in this graph is that patients with no treatment, they would rate their symptoms on a scale from 0 to, I think, 25, with an 8. However, patients, independent whether they were taking a placebo or a statin, but they took something and they didn't know what, they increased on the symptom scale up to 15 or 16. So therefore, at least the authors from this study concluded that maybe 90% of the reported issues under statin therapy might not really be caused by the statin, but by other things. And this is important for you, but also important for the clinicians. So we have to do further investigation. So we do not think, oh, this pain comes from the statins, and we don't look for other causes. You have to get an orthopedic check, neurology, rheumatology. Your GP will guide you on this, where to go next. Moving on, ezetimibe. Ezetimibe is very interesting. Ezetimibe is most often in regular practice is the second combination therapy or the second line treatment. Ezetimibe is now working indirectly on the liver by directly affecting the uptake of cholesterol in the small intestine. Therefore, the circulating cholesterol decreases, so you less cholesterol from the food you intake is absorbed. Therefore, again, we have a reduction of the cholesterol pool in the liver in the long run. And the same mechanism takes off as with the statins, as I just showed you in the liver cell. So how does ezetimibe work in patients with homozygous FH? And this is a study from 2002 done in South Africa among 50 patients who have been diagnosed with homozygous FH. And on the left-hand side, you see the whole 50 people that have been treated with ezetimibe. And here you can see that patients, when the light gray bar is shown the LDL reduction for patients that have been uptitrated from moderate intensity statin to a high intensity statin. They show a decrease in LDL cholesterol of about 7%. But in those patients who get the statin plus ezetimibe, we see a 27% reduction in LDL cholesterol. On the right-hand side, this looks very similar, and it is good that it looks similar, because on the right-hand side, because some of you who were very interested in the Tuesday session know that HoFH can be a clinical diagnosis, but more is a genetic diagnosis. So here on the right-hand side, we have those with a confirmed LDL receptor variant among those even were those with LDL receptor negative status, and we see the same effect of ezetimibe as compared to the others. So this is a really good medication in terms of LDL cholesterol lowering, especially in patients with homozygous FH. In terms of side effects, ezetimibe is very, very well tolerated. Common side effects include, however, stomach pain, diarrhea, or that you feel tired, but this is usually only in the beginning of the treatment, and this most often does not persist. Muscle pain may occur, especially if taken with statins, but also is not a very common side effect, and serious side effects are really, really rare. So therefore, this is what I wrote here. I really mean it. So firstly, what I ask you as the patients is to be consistent with your therapy, but of course only if you tolerate it. And secondly, ask your doctor and ask your experts in the field, because your health not only matters to you, but also to us. And therefore, I'm curious for the discussion.
Thank you, Julia, for your clear and enthusiastic way of presenting. And I quickly hand over to Shirel.
Yeah, thank you. And it's really empowering to know this information, especially as a patient. So now joining us is Elsie Evans, HoFH Patient Ambassador and Ambassador Program Project Manager. Elsie, I'm sure you have some important questions and thoughts, so I'll hand it over to you.
Thank you, Sherelle, and thank you, Julia. That was very impressive to see all the data about it, because I think quite often as a patient, you are told to take things and you don't always understand the impact it has. So I think we can definitely empower people by educating them so they know what they're asking for. I have a couple of questions on your presentation. So we've already looked at it, and you said that obviously the LDL receptor for homozygous specifically is sometimes a problem. And in our genetics webinar that we did, we also looked at the different variants. So if they work out your variant, would that impact on how much statin you will need?
Well, in theory, yes. However, in real life clinical practice, no. Why? Because we're talking about, with HoFH, we talk about such high LDL cholesterol starting levels. We cannot put this in quotes, not literally, we cannot give enough statin to lower. So we won't achieve a 50% reduction that we normally see with a high intensity statin. So I wouldn't try to decrease. But we have to be on the same page. I mean, it's an ultra rare disease, and we have limited data, and we really have to rely on how does this patient respond or not, and see from there. It's here more than ever, it is important to have individualized treatment.
Perfect. We know that precision medicine is where we want to go. So ideally in the future, that would definitely make a difference. The other thing that I was kind of also questioning was there's a lot of concerns in the media around statin and the impact on diabetes and possible dementia. Can you maybe tell us a bit more?
Yes. So to make it very short in terms of dementia, so the concerns regarding dementia are overcome within the scientific population. However, we know it, and it's really the other way around. We know that most dementia is driven by little blockage of the small arteries in the brain, and therefore this will be decreased by statin therapy. So we know it's not inducing dementia, but rather decreasing dementia. So, and the second topic, diabetes, or what you've mentioned first, it's a bit more complex. So what we see is statins increase the overall glucose level. Therefore, and diabetes is defined by the glucose level, by the long term, but also by the fasting glucose level. So therefore, we see that patients who are already on the edge of being diagnosed with diabetes, and they start a statin therapy, they might be just increased that little much more in terms of glucose levels to be then defined as a diabetic. This is something we see for statins only. We haven't seen this, for example, for PCSK9 inhibitors. We haven't seen this for ezetimibe or bempedoic acid. So, and there is some suggestions regarding whether this is dependent on the liver. But I think the most important message from this is all the evidence we have on the beneficial effects of statins in terms of reducing cardiovascular mortality and cardiovascular risk way outweighs the worsening effects of diabetes. And it's really not, it's not the cause of diabetes, it's just pushing you the little, just over the edge if you are already in the pre-diabetic state. At least this is how we currently see it.
Okay. Thank you. So I've got only a couple more questions and then I'll give it back to Sherelle. So one of the other things is, I live with homozygous FH. I was diagnosed when I was 3. I have cardiovascular disease to a severe side on everything. So explaining how the statin will help to actually stabilize the cardiovascular or the plaque is quite important. But one of the things is obviously with new treatments coming out, I've started taking a new treatment which impacts the intestines and things. And with taking that, what would the consideration be? Because obviously statin and ezetimibe will have their impact, but would that affect combination therapy with things like ezetimibe or PCSK9 and things like that?
So actually with the PCSK9, we know that PCSK9 inhibitors actually work better on the background of a statin therapy, because PCSK9 inhibitors overall induce a longer lifespan of the LDL receptor. And if this is now comes together with an upregulation of, we have 2 beneficial effects working on the same target. So if you tolerate the statins, in most cases, there's no need to get rid of the statin therapy or the ezetimibe.
Okay. And the last question, I'm a woman of a certain age, so we're getting a bit older. Does it affect kind of your hormone levels, and how would that affect, we have young females who have to come off statins because they fall pregnant or they're planning a family. That's quite a big gap between people getting treatment. And I know there was some thought about how that works with individuals.
No, at least to my knowledge, there's no proper data showing that statins would have detrimental effects, neither in fertile females nor in patients after menopause.
Brilliant. I have a lot more questions, but I think I'll share them later. Thank you.
Thank you.
Shall I continue with some questions that come in? There are many questions. Must there be a period between switching to another statin?
Well, actually, in clinical practice, we suggest at least a 2-week wash-off phase. So and either if it takes longer, if the muscle pain persists, but I assume it could really be statin intolerance, I even take it to 6 weeks. Yeah. But it is important to have the follow-up appointment scheduled, so there is no loss to follow up, as we say.
As you were so enthusiastic about ezetimibe, there is the question, and I'm also enthusiastic about it. Should we not give 20 milligrams ezetimibe instead of 10?
So there is no benefit in giving more. No, unfortunately.
Unfortunately, what does Lp(a)? What does statin on Lp(a) and perhaps other drugs, oral drugs on high Lp(a)?
Unfortunately, not enough. So it's that little the effect. For statins, I think there's no effect. For PCSK9 inhibitors, we know there's a 6% reduction. However, this is so little in LPL reduction. There are upcoming drugs, also oral drugs like obicetrapib, which is assumed to be reduced by 50%. There we may get into the field where it could benefit. However, for Lp(a), we really have to wait for the drugs that are currently under investigations, which are injectables that will almost like switch off Lp(a) production. And this is more likely to be beneficial.
Then a question from a doctor. Excretion via the intestine. Is there a future for therapy that way?
Well, we have the biosequestrants, and this is, I know this sounds tempting to use for a doctor because it has no systemic side effect. So what it is just, it's a medication that binds cholesterol and bile in the intestine, and you just poop it out. So, but the issue is you get severe diarrhea, you get really big tummy aches. So I think it's, if you can tolerate it, yes, but otherwise it's an issue.
There's in the
to my knowledge, there's no upcoming drugs that are going down that route.
In the chat, there is a sort of question to each other. Is statin everywhere available?
Yes. So it's off patent. There's no statin left that is still on patent. So meaning these drugs are generic. You get, but unfortunately, and I think this is where we have to move now, getting a little bit political, but I think it should be an over-the-counter drug which doesn't need prescription because we have others not.
In the Netherlands, pitavastatin is not available, but there are...
In Germany, also not, but...
Okay. Thank you for this moment, Cheryl.
Yes, I think we should move on to the next part of the discussion, which is also very important. And Professor Albert, if you'd like to introduce our speaker.
Yes, it's my pleasure, and I'm proud to welcome Professor Antonio Gallo, Head of the Lipid Clinic and Cardiovascular Prevention Unit and Associate Professor at Sorbonne University, Pitié-Salpêtrière Hospital in Paris, France. And he will share with us his enormous experience in apheresis. Antonio, the floor is yours.
Hi, Albert. Hi, everyone. Thanks very much for this invitation. So it's really a honor for me to be here and to talk about this very important treatment for patients living with HoFH. So I am excited to share some new informations with you. So these are my disclosures. So first of all, I want to remind you what is apheresis and how old this technique is, because this is quite an old lady in terms of, services for HoFH. Services because it's a takeaway service, as the meaning of this technique comes from Greece. I don't know if there are any Greek patients in the audience. You will see apheresis comes from Greek and means actually to take away, and is actually a composite word that means plasma apheresis, so take away the plasma. What is the plasma? It's just a part of the blood that is depleted of all the red and white blood cells and the platelets. So what we do with this technique is through an extracorporeal circulation. We take the blood out of the body, we treat it through a machine, and we give back all these cells and we take out the plasma. Most of all, in the plasma there is cholesterol, and so we try to be selective in taking out the cholesterol from the plasma. How does it last? It can last between 1.5 hours and 3 hours. It depends on the volume of blood that we are going to treat, and you know it better than me, it can be performed every week or every 2 weeks. There are two main mechanisms of removal of the plasma. There can be a plasma exchange, which is not a selective technique. I'm going to talk quickly about it just later. Or we can have a plasma filtration, which is a more selective technique. The guy that you're seeing in the slide is Jean-Luc Degene, who was the first to perform a plasma exchange in 1967. So I just wanted to share with you this information. So this is just about the therapeutic plasma exchange. This is not really the technique that we want to prefer when we are talking about plasma apheresis and LDL apheresis, because this is not exactly LDL apheresis. We are just putting the old blood in this centrifuge. It's going to turn, and we will separate the red, the white cells, and the plasma. So the plasma is going to be separated, but there is no filter and there is no selection of the LDL cholesterol. So we are taking out all the plasma with this technique, which means that it will need to be substituted and replaced with some other liquid, which is going to be the albumin that is then given to the patient. The point with this technique is then when we take out all the plasma, we'll take out also some antibodies, some other substances that are very important to protect us from the risk of bleeding, from the risk of infections. And so this is why this is not really the technique that on a long term we would want to keep on having. And these then are all the other selective techniques that we can use. So these are more, maybe some of these complicated names speak to you, because I'm talking about certainly one of the techniques that for patients living with HoFH are undergoing during their treatments. You can see these complicated words. I'm not going to go into the detail of them, but they actually work with a specificity of properties that are actually used in order to specifically separate the LDL particles from the rest of the plasma. So for example, in the two techniques up here, so like the liposorber, the DALI technique, or the DFPP, we have a double filtration by which we are taking the blood. We are going through a first column that will take back to the patient the blood cells, and the plasma is going to be filtered through some columns where actually with different mechanisms, rather by some electric attraction, rather by some other properties, the LDL particles are going to be selected and taken out. So the rest of the plasma with those important components can be given back and can get back to the patients. There are other techniques that are also quite efficient, but a bit less selective, that use some antibodies in these columns that are going to target specifically ApoB, or for patients living with hyperLP, apolirylA, or some other techniques with the heparin, that is a treatment to anticoagulate the blood. They are going to let the LDL particles precipitate. How can we access the body in order to perform this treatment? So we have three main options. The one that is actually preferred when it's possible is the peripheral veins needling, because we use a simple puncture on both arms. One will be the exit and the other will be the entrance, where we can then actually puncture the patient needle at every technique. So it has the advantage of having no impact on the daily activities, to be ready to use, and that does not associate with anybody misperception. On the other side, it has to be performed every time, and so the needles are sometimes a bit thick, and it can be slightly painful. Another option that is mostly used in the children living with HoFH is the arteriovenous fistula, that is safe for frequent use. That because of this, it's what it is actually. We are connecting the arteries and the veins so that we create actually what we call a shunt, which allows to go a bit faster with the treatment. The thing is that the vein gets a bigger pressure. The vein is the vessel that are supposed to take the blood from the periphery and take it back to the heart, whether the arteries take it from the heart, rich of oxygen, and go to feed the body in the periphery. So the veins are going to be a bit more charged in terms of pressure and can be a bit more charging the heart. So this means that through this technique, we would need some cardiac monitoring, and for patients that start having a fistula, we will need, this is a surgery procedure, of course, that is needed to create this shunt. We will need to wait for it to mature in order to be used. And then there is another axis that is the central venous line, that is also quite safe for frequent use. It requires also a lower treatment time, but it's something that stays there. So it can be a little bit of bothering in the daily activities, also as the fistula somehow, because it can limit some physical activity, for example. It has a higher infection or clotting rate, so it needs to be really well entertained. And for this reason, it can be used in small children, but is not really the preferred technique for a very long-term treatment. So this is really not what we suggest to have as a basic way of access. Which are the side effects of LDL apheresis? It's a technique that is overall pretty well tolerated when it's performed cautiously, when it's performed in a way that is adapted to the patient. And so when the patient has had the time to adapt to the technique. We can maybe talk about this a bit later. Some of the effects might be depending on the speed at which the technique is performed, at which this blood is washed. And so there can be some nausea, some vomiting or fatigue that can appear. Based on the kind of anticoagulant that we use in order to avoid any clotting in this extracorporeal circulation, there can be some hypocalcemia, so some paresthesia that can appear. That can be some abdominal pain or flushing or hypotension that is called this bradykinin-like syndrome that is mostly associated to certain techniques. And then, as I was saying before, some bleeding or infectious disease for the unselective techniques. Over a long time, over the long-term treatment, we can have some anemia that is associated with some iron deficiency or some vitamin D deficiency. So this is why we used to supply regularly with iron, with vitamins, and to check the levels of the iron and vitamins. And for the central venous line, we can have the obstruction of the blood lines, or even for the other accesses. So this is something that the health professionals taking care of you during the apheresis are very well trained to take care of. Just a few data from the International Registry on Homozygous FH to tell you that one of the unmet needs in HoFH, as you all know, is the access to care when we talk about treatments. And for apheresis, that is still, it has been, at least until now, the first-line therapy for HoFH, meaning that is the most efficient treatment on top of statins and ezetimibe for the treatment of HoFH, is accessible actually to only 40% of patients. So only 40% of patients from this registry were actually on apheresis. And the good news is that there was no difference between high or non-high income countries. When do we start the LDL apheresis? This is quite a busy slide, but it's just to show you that the start of the apheresis really depends on the access to it and to the access to other treatments. So based on the fact that once we have started statin and ezetimibe, that, as Julia was saying, might not be enough and are definitely not going to be enough to fully treat HoFH, we need to go for another option. So if new treatments like PCSK9 antibodies, which might or might not work, lomitapide or other treatments are available, we might try them with or without apheresis. But if they are not available and apheresis is, then we need to start a treatment with apheresis as soon as possible. So this is to answer the other question, when do we start apheresis? And this also comes from a recent consensus paper that Albert coordinated, where we could drive some conclusions and some suggestions on how to deal with apheresis. And most of all, we concluded on the fact that it's really important, based on the baseline levels of LDL cholesterol on maximally tolerated treatment, we need to start LDL apheresis as early as possible. When there is a milder hypercholesterolemia, then we still consider it, and we will check based on the presence or not of any cardiovascular risk. The efficacy of LDL apheresis is quite good because from the beginning to the end of treatment, so in the time of the treatment, we have an acute decrease, an extreme decrease of LDL cholesterol between 50 and 70%. In children, it's even at least 70%. It can be even more efficacious, with some efficacy on triglycerides and, of course, on Lp(a) as well. So this is how it goes when we start the diet, we start the statin, we add maybe some ezetimibe, and then we add the apheresis. You will see that there are going to be these up and downs that are going to be related to the treatment, but over time we observe a 30 to 40% reduction in LDL cholesterol, which in the end maybe does not make it nowadays the most efficient treatment for LDL apheresis, but still contributes to decrease the cardiovascular risk in this disease. Also because it's a treatment that is considered as LDL receptor independent, so that it does not depend, is not affected by the genetic. And this is just to conclude on some new data also here from the international registries on HoFH, on children with HoFH, where we could observe actually the efficacy of LDL apheresis on both the treatment in LDL cholesterol. You can see here that the main reduction in LDL cholesterol from, let's say, baseline, so without treatment, to the pharmacotherapy treatment, simple treatment, was about 30%, but this goes down to 55% when we add on top of it LDL apheresis. And what is most important, that reducing this, what we call the burden of cholesterol, reducing this exposure to cholesterol translates into a reduction in cardiovascular events. We had some troubles proving it before, but now, thanks to this collaborative effort and putting together all the information from all patients living with HoFH around the world, we could show that indeed the event-free survival rate, which means actually the time spent living without a cardiovascular event, was increased by at least 10 years in patients that were on LDL apheresis compared to a simple treatment without apheresis. So I just want to conclude to tell you that LDL apheresis has been a life-changing treatment in severe HoFH, as it has been also statins and ezetimibe compared to the absence of treatment before. The side effects of this treatment are largely overcome by the long-term benefits in terms of cholesterol burden and cardiovascular risk. Of course, this is still an invasive technique that is not without risks, and so for this there is a need of having specifically trained health professional teams in a plasmapheresis unit, and there are novel treatments that might mimic actually, or even do better than LDL apheresis. So for this, I think we will talk about this next week. So I want to thank you for your attention, and also let me thank the apheresis team from Paris with Dr. Saeb, that is the coordinator of this plasmapheresis unit. And I will be very happy to answer your questions.
Thank you, Antonio, for this inspiring talk, and I hand over to Cheryl.
Yes, indeed. Thank you, Antonio. You know, as someone living with HoFH and undergoing apheresis myself, it's really amazing to know what happens to your body during the process and what happens to your blood during in the filters, especially. And I'm sure we have a lot of questions as patients, but now I'm excited to introduce Maria Nassif. Maria is an HoFH patient ambassador who brings a wealth of personal insight. So Maria, the floor is yours.
Yes, hello Cheryl, thank you for introducing me and thank you for having me in this talk. I hope my experience will benefit some of you. So my first question for you, doctor, is I have done apheresis on the same machine that you have mentioned in your slides in 2 different countries, but in one country my apheresis was 2 hours and a half long compared to 45 minutes in the other country. but the results came better in the longer apheresis than the other one. Can you please explain why the speed might be important for the apheresis?
Yeah, so actually there are two things actually that could explain the difference in the duration. Rather, you decide to treat less. So the total volume that you're gonna let through the machine is gonna be lower. And at the same speed, you're going to treat less. So it's gonna be less effect. Rather, you choose to treat kind of the same volume, and you choose to go fast. If you choose to go too fast, this might be actually quite risky in terms of effects, in terms of fatigue, in terms of, let's say, overall tolerance of the technique. Why this happens? Because when you go too fast, you don't let the blood the time to actually enter in contact with these famous columns that I showed you, and to actually let the LDL particles be kept and taken away and actually effectively, efficaciously filtered and given back, to the machine. On the other side, the speed of the technique is really, really important, and which is why when we start LDL apheresis, we really go slow, and we decide to go both slow and to treat lower volumes to really accommodate and let the patient get used to the machine. So this contact with the machine is really fundamental when starting LDL apheresis.
So can you know how can we make the apheresis longer on the same machine without making the blood coagulate?
Sorry?
How can we, on the same machine, have the longer apheresis without the blood being clogged during the
without being clogged. So the whole circuit, you have to know that it's completely closed. So there is no opening to the external. So it's still an extracorporeal circulation, but it's still a system that is closed. And there is an anticoagulation process that goes on all the time. So the machine is prepared when we, connect all the tubes. Is going to be prepared, and it's going to be the whole circuit is going to be anticoagulated with a lot of units of heparin. And during the treatment, there is also some anticoagulant. There is, according to the treatment and the technique, there is going to be perfused, and that keeps the anticoagulation going on. Of course, this anticoagulant in certain technique is not given back to the patient in order not to increase the risk of bleeding.
Okay. As a doctor, have you observed any good modifications in a patient having HoFH?
After the apheresis?
Yes, on a long term. Did you have any observations in the patient's life with HoFH?
Yes. We have quite impressive stories and quite impressive memories of patients coming with extremely evident deposits of cholesterol, like very hard xanthomas that after a period of treatment would completely get empty and would completely disappear. So this has been one of the most, let's say, eye-speaking results. Now, talking about the fact that these patients, when the treatment is efficacious and it's well kept and well followed on a long term, do not experience any more cardiovascular events.
Yes, that's amazing. Do you think there should have guidelines that should be followed internationally by healthcare professionals, and how can we put them in place?
Yes, this is important. It's important that the use of the techniques is quite, homogeneous, because this is a rare disease. We don't have to forget. Often nephrologists perform these apheresis, but it's not like dialysis. So it's not the same. It's not exactly the same technique that is used for patients with with kidney disease. So it has some specificities that need to be taken into account. And as I was saying, the speed is not necessarily the same as when we do dialysis, not at all. And there are now some common international recommendations that have been published just at the beginning of the year that can be used by all health professionals in order to get used with the technique. There is also one thing that is important, and this that usually nurses and doctors come to specialized centers for a training of 1 week, and we are always happy to welcome them in order to have in the daily life practical experience and training with actual machines, with actual patients, and to see how it really goes.
Okay. That's so amazing to hear that. Thank you so much, doctor. I think I have so many questions, but I think let the floor for participants if they have questions.
Great of you, Maria, to have so many questions, and good to listen to you and the answers. 2 questions about stopping. One is because a person said, I feel tired after apheresis. Is it not better to stop?
Well, tiredness after apheresis is one of the side effects that actually is one of the most common effects. Yeah. It is still a sign of efficiency of the treatment that might be, rethought once maybe new treatment could be added. But the first objective is that this treatment being the most efficacious today, we need to take care of of attaining some targets and of being sure that we are doing some prevention of the major complications of the disease, which is cardiovascular disease. So the tiredness has to be reported to the doctor, and this can have as a consequence an adjustment of the technique, but I wouldn't say that this would suggest to stop the treatment. No. The treatment is still saving you.
We see it in all the children that they are tired on the day of apheresis, but the day after they are feeling much better.
Exactly. It's just
the
one
other
day
question about stopping is, if you are on goal, is it then wise to stop the apheresis?
Well, this is going to be the future for quite a number of patients living with HoFH. Once we are on goal, we can really think that apheresis might not be necessary anymore. What does it mean to be on goal, though? We need to be careful in checking exactly that cholesterol is really going down. And I'm not talking about the cholesterol after the apheresis. I'm talking the cholesterol before the apheresis, because that's the cholesterol that is going to tell you if you are on target or not. So if you are on goal before the apheresis, then this means that you won't need the apheresis anymore.
Yes, thank you. Apheresis on LP. Oh, sorry, LC, please.
Sorry, I was just going to ask a question because I like to ask questions. Apheresis, I know, is for some people who have started young, very important, and they're very relaxed with it because it's part of their daily routine. I didn't start apheresis until I was in my late 20s. So it was quite a shock to the system, to say the least. It's for me, I find it very invasive, very tiring. It impacts on travel, or work, all these things. So when I started a new treatment, they kind of went, that's great, we can stop apheresis. That lasted, which was great. And then 18 months later, it was like, nope, you have to start apheresis again because you're not reaching your goal. I understand that, but also keep in mind that when I was diagnosed when I was 3.5, and I know that's a long time ago, goal was if you can get to 6 or 7, that was fantastic. Goal now is very, very different and quite difficult to achieve, I think, for a lot of patients. So that's one of the things, is actually how does that work out? And another one is, so we take statins, we take ezetimibe. When we go for apheresis, all of this kind of washes out to a certain extent.
Okay.
Does that mean we have to do differently?
Let me answer first the second question, which is a bit easier. Actually, it doesn't wash out because the treatment are quite well absorbed, and so studies haven't shown any lack of efficacy of the baseline treatment once you're treated with apheresis. For PCSK9 inhibitors, the story is a little bit different because we do at least try to perform the injections at the end of the apheresis in order not to impact on any possible washout. To answer the first question, which is more difficult actually to answer, I do completely understand the burden that apheresis represents, and the fact that we started earlier on children doesn't mean it's not as a shock as it is for an adult, because still it's a lot of constraints, it's a lot of things to adapt to your daily life, because it's one day at school that is that goes away once per week or twice per month. It's not something that, it's not an easy thing. And all the organization for the family also to adapt. What changes with the treatments and with the progressive lowering of the targets is that, first of all, we have new evidence that there is a residual cardiovascular risk when we keep levels of LDL cholesterol still at a certain target that before it was the maximum that we could achieve. So we have new treatments that now allow to really go down, and that allow us to see that there is still a protection there in terms of cardiovascular risk. When we start this treatment that put us on a lower target before, and when there is no cardiovascular disease at baseline, we might be able to protect from the risk of cardiovascular disease without necessarily achieving the lowest target ever. Because if we do not develop cardiovascular disease, then we might not need to be that ambitious. So this is how this paradigm could shift. But
thank you.
It's a long way to go.
Questions for you, but I go to Julia, because there is a question about the generic versus the brands. Are they working the same, or is there a difference? So those from the company that came, the Crestor and the Lipitor, and nowadays the Atorvas and the Rosuva's.
So, firstly, yes, they do work the same. They have the same molecule inside. Secondly, still there might be differences in terms of formulation from company to company that formulate these things. If you are lactose intolerant and it's mixed with lactose, then you might get issues. So to be honest, in clinical practice, you see patients that say, okay, I tolerate this, but I don't tolerate the other. I think it's really depending on the formulation of the stuff that is mixed within this tablet, besides the molecule that is active.
Mm-hmm. Thank you. Also questions for you, but we have to do these afterwards on paper. Lp(a) for apheresis, Antonio, is Lp(a) lowering if you have high Lp(a) in combination with homozygous FH?
Yes, it lowers about 50%.
So, but you don't do apheresis just for high Lp(a)?
No, we don't do it. There is actually a technique that is performed, I think, in Germany specifically for Lp(a), but actually all LDL apheresis takes out also some 50% of Lp(a).
And if there's time, how long will apheresis work? Is it a matter of days or weeks? Some do it once per fortnight, others do it weekly, some do it twice a week.
Actually, there is a rebound of the LDL cholesterol, meaning that it goes back to the highest level about 1 week before latest. So for the most severe forms, when the levels of at baseline are very high, we would need to have weekly treatments. Otherwise, we can do it every 2 weeks.
Cheryl, is it?
Yes.
I think time is up.
Yes, I think it's time to wrap up. I wish we can, stay here for like 2 days.
Yeah.
I'm sure we have a lot of questions. But if we didn't have the chance to address your questions today, don't worry. We'll be following up with the answers in our post-webinar email. And as we wrap up, I hope this discussion really get to people all over the world, because we know that not every country has apheresis, and we know how crucial it is to, have apheresis as an HoFH patient. And I'd like to thank our panelists for sharing their time and expertise, and to all of you for joining us. And we hope this session has been insightful and has given you a deeper understanding of these golden standards in managing HoFH. Now, before we let you go, quick reminders: the recording of the first webinar on genetics and gene therapy will be available soon. And our upcoming final webinar of this trilogy, the recent trio treatments in HoFH, will be scheduled on September 26th, and the FH Awareness Day webinar on the 24th of September. So the registration links for both webinars are available in the chat, so be sure to register and join us for more engaging discussions. I also want to draw attention to the HoFH logo competition, which is still open for submissions. This is a great chance to express your creativity and to help shape the identity of HoFH Awareness Day. So we encourage everyone to get involved or to share the competition with others. My last quick reminder that FH Awareness Day is approaching on September 24th, and there's still time to join our campaign. So you can support by liking and sharing and engaging with our social media posts. And we also have a toolkit available on our website to help you spread the word. Lastly, we want to thank our partners and our sponsors for their support, which has played a big role in the success of our recent initiatives. So once again, thank you, and we look forward to seeing you at the upcoming webinars.